So our session beginning this TCTAP 2021 this morning is left main and bifurcation PCI. The moderators are Dr. Spencer King and myself, Yves Louvard, and the panelists are Adrian from UK, Alaide Chieffo from Italy, David Kandzari from USA, Do-Yoon Kang from Korea, and Sunao Nakamura from Japan. Please, Dr. King.
All right, the first talk this morning, today, will be individual decision-making between CABG and PCI for multivessel or left main disease. This will be the expert surgeon's view, and we're very happy to have an expert surgeon, Mario Gaudino from Weill Cornell Medical Center in New York.
Thanks for the privilege of being here, the only surgeon, and with all the interventional cardiologists at 5 o'clock in the morning. It's kind of scary, but I will survive. So my task is to discuss my opinion as a surgeon on treatment of patients with multivessel disease and left main. And I have no conflict of interest to disclose. I think I will start by saying that the controversy about the treatment of a patient with multivessel of left main coronary disease, in my opinion, is more apparent than real. After more than 2 years of randomized study on the two different interventions, I think we all agree that the published evidence very consistently show that the CABG and PCI have a very different risk profile and very different time-varying benefit. In addition, patients that we see every day in clinical practice have most of the time clinical or anatomic characteristics that very clearly drive the decision between the two treatment modality, and there are very few patients where there is real equipoise between the two technique. So it's probably time to abandon even the idea of this controversy and just get over it. Not sure why. Okay. So, well, you have seen these slides hundreds of times. I will just go over them very briefly just to show you how the result of the different studies are in reality pretty consistent one with the other. In Nobel, we all know at 5 years, surgery was superior in terms of a composite outcome that included repeat revascularization and excluded perioperative MI. There was no difference in survival. There was a significant reduction of spontaneous MI by surgery and of repeat revascularization, and no difference in stroke. When we look at the Excel trial, well, results are in fact similar because PCI was not inferior for a composite outcome that excluded repeat revascularization and included perioperative MI. But for the secondary outcome that included repeat revascularization, surgery was better. And when we look at the individual component of the composite outcome, there was this time a difference in survival in favor of surgery that, however, was unadjusted for multiple comparison. No difference in stroke. No difference overall in MI, but the curve were clearly crossing, and CABG was associated with a higher risk of periprocedural MI and a lower risk of spontaneous MI, and the well-known effect of CABG on a reduction in ischemia-driven revascularization. I think this is really the most important, at least in my opinion, message from Excel and probably from all the trials that have compared the two interventions. During the first months after the procedure, well, surgery is clearly associated with a higher perioperative risk and also a higher discomfort for the patient. During the first year, the two interventions are superimposable, and then starting from the end of the first year, the two curves start separating. They are clearly separated after 2 years, and there is a long-term benefit with surgery. And when we look at the quality of life of the patient, well, the story is even more clear. You see how in terms of relief of angina, of treatment satisfaction, they are more or less superimposable. But the price to pay in terms of quality of life during the first year after the procedure is clearly higher for patients to receive the surgery. So surgery requires a higher price to pay up front with a higher operative risk and lower quality of life for the first year, and lead to long-term benefit. Depending on the baseline profile of the patient, the life expectancy, the frailty, the surgical risk, one or the other treatment are clearly indicated. I will not go over the detail of the controversy about the definition of myocardial infarction in Excel. Professor Serruys will do that much better than I can do. But I think the take-home message for me here is that we really need to have a definition of perioperative myocardial infarction where we all agree on, because the use of different definition is really driving the outcome of many of the trial in cardiology. The different trials have been pulled in different meta-analysis. Again, I will be very, very short on that. This is a meta-analysis on the European Journal of the left main trial. No difference in survival at 5 years. No difference in MI, even though here perioperative and spontaneous events were pulled together, and the known effect of surgery in terms of reduction of repeat revascularization. This is another meta-analysis on a surgical journal, and the results are consistent, no difference in survival. This time, the authors looked only at spontaneous MI, so there is a reduction with surgery, no difference with stroke, and a significant difference in favor of CABG for repeat revascularization. I think in the end, we all know the reason for that. The two interventions are different. PCI mainly treat flow-limiting lesion. Surgery provide the surgical collateral distal to the flow-limiting lesion that in the long term can protect even toward the progression of lesion that were not flow-limiting at the time of the intervention. So my conclusion, PCI and CABG are clearly different interventions that are performed in different patients with different aims. Surgery is associated with a higher periprocedural risk and higher discomfort for the patient, but better clinical outcome in the long term. PCI assure outcome comparable to surgery for the first 1 to 2 years, with much lower invasiveness. The two interventions must be seen as complementary and not antagonist. And that was my slide, my last slide. I thank you for your attention and for the privilege to be part of this meeting.
Well, thank you, Dr. Gaudino. Everything seems clear, except now we'll have Dr. Patrick Serruys, who is now at National University of Ireland in Galway. And Patrick is going to talk to us about chaos in procedural MI definitions in trials comparing PCI to surgery and how we can reconcile this. Patrick?
Okay, chaos in PMI in trials comparing PCI versus CABG. How do we reconcile? This is the title proposed by the Scientific Committee of TCTAP. The October issue of JACC has 2 papers on the issue of periprocedural MI, one from the Excel group and one from the syntax group. And accompanying these 2 papers, there was an editorial of Don Cutlip entitled Procedural MI Definition Everywhere, but not any that may fit. What is the advice of Don Cutlip? He said we may be forced to accept that the same procedural MI definition cannot be fit to both procedures. Determining that threshold remain the topic of debate. If we cannot find definition that fit these purposes, then perhaps it's time to remove procedural MI from primary composite endpoint. The rationale for using PMI as event in trials is that PMI as a dated event has been integrated as a critical item in composite endpoint. Its definition encompasses a variety of combined of isolated phenomena, such as enzyme elevation, permanent ECG change, anatomic occlusion of vessels, and loss of viable myocardium. Conversely, the clinical relevance of a PMI should be defined as a PMI leading to death, reintervention, or hospitalization for heart failure. And isolate enzymatic PMI events, quote unquote, are frequently incorporated into time to event composite endpoint to satisfy trial designers in search of a powered sample size, but they may artificially influence the interpretation of the real benefit of a novel treatment. Which definition should we use? 5 PMI definition were applied to the syntax trials using only CKMB, and in the syntax trial we use a combination of at least 5 CKMB with ECG criteria, a new Q-wave in 2 leads. In the 4th universal definition, when using CKMB at a level of superior to 5 times the upper limit of normal, the definition had to be associated with ECG changes, angiography, or imaging evidence. And the level of CKMB for surgery, the threshold was then 10 times the upper limit of normal. In ischemia, the level of 5 CKMB has to be associated with additional criteria, but isolate CKMB 10 times upper limit of normal was a sufficient criteria, while the threshold in CABG was 10 times the CKMB upper limit of normal when associated with additional criteria of 15 upper limit of normal as an isolate threshold. In SKY, something similar was proposed for both PCI and CABG, and SKY and Excel are almost identical. So in ischemia, SKY and Excel, we have the isolated criteria of 10 times, 15 times CKMB without additional evidence of infarction. And in the 4 universal definition and ischemia, we have different threshold of CKMB for PCI and CABG. According to the syntax definition, PMI occurred within 48 hours in 2.7% in the PCI arm and 2.4% in the CABG arm. The numbers of patients with a PMI according to the 4th universal definition were similar to those identified according to the syntax definition. Using the ischemia definition, 6% and 8% of patients suffered a PMI in the PCI and CABG arm respectively. And when applying the SKY and Excel definition, PMI after PCI were identical, 5.7% suffer a PMI, while 16.5% suffer a PMI in the CABG arm. And most of the PMI event according to ischemia, SKY, and Excel definition were solely driven by enzyme criteria. This slide in the JACC paper shows the MACE rate at 1 and 5 years in the syntax trial. They were higher in the PCI compared to the CABG arm when using the syntax, the 4th universal definition, and ischemia definition of PMI. And the curves kept diverging with very similar percentage of event at in PCI and in CABG at 1 year and 7 years. In contrast with the SKY and Excel definition, the Kaplan-Meier curve has a totally different profile with at 1 year a higher rate of event in the CABG group, while the 2 curves cross over at 3 years and then were quite similar between PCI and CABG at 5 years. The next question is the impact of PMI on all-cause mortality in syntax, which definition in clinical is clinical relevant. After adjustment for baseline characteristic according to the syntax definition and the fourth universal definition, PMI after PCI remain an independent predictors for all-cause mortality at 1 and 10 years. In contrast, PMI after CABG was only an independent predictors for all-cause mortality at 1 year and not at 10 years. And similar statistic results were observed with the fourth universal definition. What about the Excel trial? If the CKMB is the preferred enzyme with a CKMB level above 10 times the upper limit of normal, in the Excel, there were no need for additional evidence, whereas with a threshold of 5 times the upper limit of normal, either ECG or angiography of other imaging evidence were necessary to comply with the definition of PMI. And with the third universal definition, troponin is the preferred enzyme and additional evidence are always mandatory, ECG, angiography of other imaging evidence, both for a threshold of 5 times the upper limit of normal and a threshold of 10 times the upper limit of normal. This slide shows in the Excel trial the peak procedural CKMB and the troponin level. 2 observations. 1, the correlation between CKMB and troponin is moderate with a Pearson coefficient of 0.63, and it's clear that PCI, the blue dots, have lower level of enzyme than CABG, the red dots. This slide showed the PMI rate according to the universal definition and Excel definition, and then the impact of PMI on cardiovascular death in the Excel trial at 5 years. On the left-hand side, we have the percentage of patients with PMI. In blue, the post-PCI, 3.6%, and in red, post-CABG, 6.1%. When the universal definition is used, the percentage are reversed, higher in PCI, 4%, and lower in CABG, 2.2%. On the left-hand side, the adjusted hazard ratio for 5 years cardiovascular death are not different with the Excel definition, while the universal definition in the Excel trial is highly predictive of 5 years mortality in CABG, with an adjusted hazard ratio of around 12, suggesting that additional evidence of MI play a major role in the long-term prognosis of PMI. Which enzyme should we use is the second question. What thinks the surgeon? And let's go back to purely surgical trial comparing CKMB and troponin and looking at the 30 days mortality in these 19,000 CABG patient pool from 7 studies. The relative risk of mortality is around 3 for a CKMB above 5 and increased progressively to 4.4, 8.7, and 27 for CKMB more than 10, more than 20, and more than 40. With troponin, you see a level superior to 40 to have a significant relative risk of mortality of 3.6, and it raised to 11 with a troponin higher than 100. As a conclusion, CKMB could be recommended as a cardiac enzyme for PMI in CABG compared to troponin. To finalize the chaos, what thinks the interventional cardiologist? Recently, European investigators have collected the troponin in 9,801 patients treated with PCI. More than 1 time the upper limit of normal was found in 52.8% of the patient, more than 5 times the upper limit of normal increase in 18.2% of the patient, and more than 17 times the normal threshold, corresponding, by the way, to the R2 definition of MI, is found in 1.05% of the patient. And the adjusted odds ratio for 1 year mortality increased progressively from 2 to 3 for 5 times the upper limit of normal and 70 times the upper limit of normal. At the level of 70 times the upper limit of normal, the specificity would be 99.4%. So the authors conclude that isolated troponin elevation of more than 5 times the upper limit of normal is associated with 1 year mortality and could be used to detect major procedural myocardial injury in the absence of procedural complication or evidence of myocardial ischemia. In conclusion, yes, current chaos exists. Based on survey in hospital, CKMB is progressively leaving the scene, replaced by troponin, including high sensitivity. There is one school who said MI is not an isolate release enzyme, but has to be accompanied by a permanent, irreversible sign, a new Q wave, wall motion abnormality, loss of viable myocardium, vessel occlusion, name it. And myocardial injury is not synonymous of myocardial infarction that has a different physiopathological mechanism after CABG and PCI and different clinical reference. And the other school said isolate troponin elevation above 5 times upper limit of normal is associated with 1 year mortality and could be used to detect major procedural myocardial infarction. The TIMI group will review the PMI of the syntax, pre-combat, Excel, and novel studies independently under the leadership of Eugene Braunwald and Mark Sabatin. And on the other hand, the Academic Research Consortium will try to redefine the definition of PMI. Ultimately, we could eliminate the I-10 PMI from the equation of composite endpoint, since a clinically relevant MI is ultimately translate in early or late death of heart failure. At the end, for all patients, a long, enjoyable life is their personal prospect. And for us trialists, it has a name. It's called Quality Adjusted Life here, QALY. Thank you very much.
Thank you, Patrick. We'll come to some questions regarding these talks at the end of this session. But now it's a pleasure to introduce our host for TCTAP, Seung-Jung Park, who's going to talk to us about the updated left main revascularization 2021 and perspective on new guideline changes. SJ from Asen Medical Center in Korea.
Thank you, Spencer.
Very well.
All right, I want to start with everybody know that the first bypass surgery is in 1960, Dr. Goetz, and after 1977, bypass surgery and PCI debate has been long lasting ever since balloon angioplasty started in 1977. So up to this point, during almost 30 years, lots of changes, guideline changes, and 2018, actually the PCI would be an effective alternative in a selected patient group who had a lower, intermediate risk group. Efficacy concern, there is recent published data, individual patient data pooled analysis is 11,000 patients, including the bare metal stent and syntax pre-combat. Novel Excel study actually cleared for the specific, separation with a multivessel disease and main is absolutely no difference in terms of all deaths. We had performed several years ago the syntax-based pre-combat patient level meta-analysis. The main subset clearly showed that no difference at all, even composite endpoint dash MI stroke at 5 years. And if you look at the multivessel disease, absolutely bypass surgery is better. However, main and any 2 to 3 vessel disease very equipoised between the PCI versus surgery. This is another, IRIS registry, main registry, one of the biggest registry. Dash MI stroke, composite endpoint, no difference. Dash no difference. Only difference is spontaneous myocardial infarctions at 3 years, clearly higher in a group of PCI. Subgroup analysis and the young ages as a PCI better. The patient group who had a heart failure, history of heart failure, chronic kidney disease, and low ejection fractions. Recently published our data. Ejection fraction less than 35%, severe LV dysfunction for those patients is still bypass surgery is clearly better than the PCI. And so I would briefly, summarize consensus up to this point. In patients with low and intermediate risk anatomical complexity, PCI with drilled-in stent and bypass surgery showed a similar mortality and serious composite outcome. PCI was also associated with a high risk of repeat revascularization and low risk of stroke compared to the bypass surgery. Bypass surgery may be better in patients who had a history of heart failure, chronic kidney disease, and low ejection fraction less than 35%. And we needed some long-term data. The recent published lots of data. We have already seen that the Excel study and Novel study and short-term follow-up 3 years, 5 years, they clearly show some, bypass surgeries over favoring bypass surgery over PCI, some kind of a crossovers, rate catch-up phenomenon. And the recent, 2 main study clearly, published 10 years follow-up data. Syntax 10 years, Lancet 2019, separate with the 3 vessel and the main disease. Absolutely no difference, 28% bypass surgery, 27% in the PCI. Pre-combat our randomized studies, PCI versus surgery, 10 years follow, we published last year, even including the soft endpoint, ischemic-driven TBL, actually not statistical difference between the 2. Pre-combat 10 years, all deaths absolutely same, 14.5%. and 13.8%. Novel 5 years, so you have already presented last year's primary endpoint. Non-procedural MI included repeated revascularization, clearly better outcome in PCI. However, all deaths absolutely same, 9.4%, 8.7%. Excel studies, lots of issues, debating, all composite endpoint, all deaths, stroke MI at 5 years, not statistically different. However, the clear crossover, we have already, seen this slide. All deaths actually some, statistical difference between the 2. So lots of debating issues. Everybody know that David and Greg Stone and debating the issue, just the 2 major issue. Problem is all deaths will be higher in a group of the PCI. Just Patrick, give us a lot of insight, procedural MI issues. And so David really are concerned about all deaths is really most important outcomes, and the correct answer may be related with late cancer, sepsis, non-cardiac cardiovascular deaths, definition, concern of periprocedural MI, lots of issues. However, this is a protocol, specify the periprocedural MI is before the Excel study. So I would say Excel trials is well-organized studies. I know that, including a large number of patients. However, this study is just one of those randomized studies, and randomized study actually can provide us a limited and finite information. So I would say, please calm down, David, and totally understanding your point, but pulling yourselves together, please give us more practical guideline, right? I know that the periprocedural MI definition-wise, all that. However, lots of data so we have, and if you look at the practical practice changes during the almost 30 years, big changes. That is extreme. So in our lab, as more than 75% would be treated with the drill stent. However, average and 60% of the main disease should be treated with a stent column practice. And so I would say clearly we have to realize main disease is not surgical disease anymore. So I would like add some future perspective, the main revascularization. So we have to consider issue of complete versus incomplete revascularization for concomitant coronary artery disease, FFR-guided functional revascularization for concomitant coronary artery disease. And high syntax score combined 3 vessel disease, surgery is still better for those patient group. However, if you look at the impact of complete revascularization, I want to just show our subgroup analysis of the best trials, multivessel disease. Actually, the patient group who incomplete revascularizations, not statistical difference, only difference is high rate of spontaneous myocardial infarctions, 7.4%. And however, in case of a complete revascularization, absolutely disappeared the difference in terms of frequency of myocardial infarction. And we've learned from the best studies, subgroup analysis, spontaneous MI, new region revascularizations may be related with incomplete revascularization. And we have another meta-analysis, syntax-based pre-combat. Look at this, any death, MI stroke, PCI incomplete group is clearly higher. However, in group with the PCI and complete and conventional bypass surgery is quite similar, composite endpoint, MI stroke. And so we will learn complete revascularization of multivessel disease had a comparable clinical outcomes with the conventional bypass surgery. So complete revascularization is very important practical issues for better clinical outcome. Look at this, Excel trial, supplementary appendix. I would like to find out, how many cases of multivessels included. However, it's very difficult to find. Anyway, number of vessels treated, main and the others, coronary artery disease. Look at this, almost 60% had a combined disease treatment. Number of stent 2.4, number of point 2.6. If we get some data during the, this is for follow period, ischemic driven non-target region revascularization is clearly higher, with PCI, and target vessel, non-target vessel revascularization higher. Of course, the ischemic driven repeat revascularization clearly, higher. And then if you look at some subgroup analysis, the non-main disease coronary artery treated 2 region subset and 3 region subset. In case of 2 region subset is clearly, bypass surgery to be better. So our pre-combat trial, supplementary appendix, so we found that with the pre-combat studies included more than almost 90% has a concomitant the other coronary artery disease, single vessel, multivessel disease more than 75%. Number of stent 2.7, number of conduit 2.2. Still, we have almost a similar, subgroup analysis. Main with the triple 3 vessel disease, clearly better outcomes in case of a bypass surgery. And so I would say in the arm of PCIs, we have no clear ideas in terms of complete revascularization, incomplete revascularization issue. So second one's impact of FFR. This is Patrick's data syntax 2 trial. He compared with the syntax 2 PCI arm and bypass surgery. Right, last slide. After the FFR, IFFR, reason treated patient is absolutely decreased, and case of cerebral PCI in syntax 2 just only 37% compared to the 83% in syntax 1 study, clearly demonstrate MACE, major cardiac adverse event, including death, cerebrovascular event, NMR, any revascularization, absolutely same between the syntax 2 PCI functional approach and syntax 1 bypass surgery. The clinical outcome concern is quite similar. So I would say the syntax 2 trials we've learned outcomes of physiology-guided PCI are comparable with the conventional bypass surgery for patients with the cerebral disease. PCI outcomes are not related with the syntax scores and conventional concept of incomplete revascularization. Actually, you have combined concept of functions, FFR. I think it is totally a different world. So I would say kind of practical guideline in my personal perspective, main only and then main and 1 and 2 vessel disease, PCI is good alternative to surgery. Mainly the combined 3 vessel disease, if we consider concept of complete revascularization with the FFR for combined 3 vessel disease, even in the high syntax score, PCI would also be a good alternative to surgery. And main PCI concern current practical issues, true bifurcation disease, upfront to stent implantation would be recommended. If lesion is functionally significant and the favorable anatomy for PCI, complete revascularization should be considered. The reason is unfavorable anatomy and low ejection fraction, so lots of comorbidities later, send the patient to the surgery. Thank you. That's my summary.
Thank you, SJ. We have some time for Yves. Let me ask you one, and then you please take over. Since this whole business of what the endpoints are in trials and how we interpret trials and how we use these trials, it occurs to me that periprocedural MI is not, from the patient perspective, a clinical event, and apparently also not from the operator's perspective, not a clinical event, because if it was, we would measure enzymes, and we don't measure enzymes outside of trials, at least in my center. With PCI, the enzymes are not routinely measured. So if we're not measuring them, why should we count them as an endpoint? The patient has no awareness of whether their enzymes are elevated or not unless we tell them. So something that's not a clinical endpoint, what's the rationale for including it in a clinical trial? Does anyone want to weigh in on that?
I can start. Yeah, I think that you make your point. I think that in the early days of trials, certainly bypass versus PCI, one of the big issue was to have a correct sample size and the correct power calculation. So it was difficult to do that with mortality alone, mortality and stroke alone, even mortality, stroke and MI. And that's the reason why we introduced these periprocedural MI. But you also emphasize the things that it is in some way not relevant for the patient. Of course, we always recuperate the potential damage done at the time of the procedure by later death, by arrhythmia, heart failure, of other reason. So I suspect that it might be that when we will have the ARC meeting on periprocedural, there will be strong voices about let's drop that, but it will create an issue with the sample size in the future. But we are going to the big data. I mean, obviously, when Jean Bonwall is pulling all these patients together of the 4 trial, he doesn't need to have peri-procedural MI, death and stroke and MI. Every item is somewhat powered.
Yves, any question from you or the panel?
I have a question for Patrick again. Do you have an idea on how the CPK was measured? Was it a measurement at the defined time versus the surgery or PCI? Was it the pike of a curve? Was it the surface under a curve? I say that because we know that when you have a vessel which remain patent, which is probably more frequent in surgery because we have 2 vessels, then you are more release of CPK in the blood, explaining a high peak and a large curve. So this maybe make the difference between in measurement between the PCI and the surgery.
Absolutely. I mean, clearly, surgery and PCI are 2 different animals, for sure. If you do a bad cardioplegia in a surgical case by accident or for other reason, you will have enzyme. While in PCI, it's more the duration of occlusion and the permanent occlusion of a side branch. So the physiopathology of the source of enzyme in these 2 modalities of treatment are quite different. So that's also very difficult, and you see in the different definition, sometimes the people take care of that. I mean, for PCI is 10, but for surgery is 15, etc., etc. In the early days with Frederick Moore, he insists to have an enzyme, and he put the threshold to 5 CKMB, and a Q wave. A Q wave alone he was also not accepting, because in surgery you can have a pocket of fluid in the pericardium which will give you a Q wave. So it was basically the 2. And as I said, some of the school considered that enzyme should always be associated with something else. But then we come back to the question of Spencer King, is that necessary? Are we not recuperating the concept of peri-procedural MI in late death, of late heart failure, of fatal arrhythmia? That's the question.
May I just give a comment? The first, the putting together the data from these different trials. Clearly, this is fascinating for the number of patients and data, but clearly you have to take into account the different definition of all the trials and different patient population. So it will be interesting to see how they will overcome this issue, because I think it's a big issue. We see when we see different trials, I'm thinking about Noble and Excel, results are completely different. So this is something that we have to deal with, and this is my question to Patrick, if he thinks he knows the insight on that. And the second, I think, is even more fascinating, your conclusion on the patient-related outcomes, because honestly, I think this will be the future. At least European Society of Cardiology is moving in that direction, and for future trial and for all the trialists, I think that we should move in that direction, because elevation of enzyme is something that a patient can have completely asymptomatic and is not going to impact to their life. Indeed, we should concentrate on patient event, on how the patient see the different events.
Short response to your comment. Indeed, I mean, if you think in 2007, and we create ARC, and we create ARC because we were at that time struggling with the definition of stent thrombose, only stent thrombose, and then came the definite and the probable, etc., and the possible, and we dropped the possible. So the ARC on peri-procedural MI will be an interesting exercise, academic exercise, and I think it will go in 2 completely opposite directions. One is dropping it, the other is imposing something where probably because the troponin is coming more and more in the hospital and less hospital are doing CKMB. Every time we do a survey, we see the number of CKMB in the hospital dropping. But the second point, I fully agree with you. You know, we have in our family, parents, we have got PCI of bypass surgery. At the end of the day, what counts, I am alive and I'm playing golf or fishing or going with my grandchildren. That's what counts. And qualities will come back. The point of qualities is two issues. You have to do frequent survey, which is not easy. At some point, the patient get tired of the questions sent by Dr. Chieffo. I mean, come on. And the second point, it requests big numbers and long term. You know, in the global leaders, 16,000 patients, it took me 1 year to get the vital status of everybody except 8 patients. So it's hard work to do qualities, yeah? But it's the essence.
That's the point, isn't it? About the number.
Well, I was just going to add that just to expand on that issue, since we have the advantage of having a surgical colleague with us, is that and a very much overlooked influence of the decision making. There's been so much focus on the heart team, but it's not to consider the patient's perspective. To your point, Patrick and Alaide, and specifically, if we look at we appropriately focus extensively on heart events, death, myocardial infarction, to some extent repeat revascularization. Many individuals are willing to trade off, for example, in the Excel trial, 6% difference in repeat revascularization for similar outcomes of death and myocardial infarction. But even more than that, it's to consider the composite of adverse events with bypass surgery that might include a higher likelihood of renal failure or transfusion or mediastinal infection, atrial fibrillation, among other issues. And if you look at it from a health economist perspective too, for instance, the composite of adverse events may actually exceed that of PCI even over long-term follow-up. And part of it's reflected in the Excel trial that when we look at follow-up events, even for repeat revascularization, despite consistently being higher for PCI versus bypass surgery, interestingly, in the Excel trial, among patients randomized to PCI, the performance of bypass surgery over long-term follow-up remains very, very infrequent in the single digits.
Let's let Mario finish this up by responding to these things. So we've presented a lot of data from trials showing that surgery is better in some respects, but as SJ showed, surgery is not done very frequently, at least in Korea and many other places, for left main disease. So what's your reaction?
Well, I think again, in some patient with left main disease, surgery is the appropriate intervention. In some other patient is not. I don't have a clear-cut answer. Something I want to add from a purely surgical perspective, 2 things. First of all, when you discuss myocardial enzyme release after surgery, is not really only cardioplegia. You know, we physically cut the myocardium to expose the vessel, to cannulate the heart. Most of us amputate the right atrial appendage for cannulation purpose. So the myocardial enzyme release is due to surgical incision of the myocardium, not only to cardioplegia. Another point that I think must be considered is that, you know, that isolated left main for the surgeon is not a great case, because with isolated left main, you have always concern about competitive flow. And if, like me, you mainly use arterial graft for your revascularization, that is even more problematic. So even as a surgeon, I totally agree that isolated left main, if it can be treated by PCI, well, for me, it's much less pain. It's not a case that I would personally be happy to do. Left main with multivessel disease in a young patient with long life expectancy, well, I think that the benefit of surgery in the long term may pay over. So again, it is, I know it's not very smart, but my take-home message is it depends on the patient and probably also on the physician who make the procedure.
Well, thanks. We've come to the end of the allotted time, I believe. We would love to continue this conversation for many hours, but I think that's not an option. Yves, do you want to introduce the speakers in the next session, or shall I continue?
Thank you, Spencer. I'll do. Thank you very much.
Okay.
So the next chapter is about bifurcation PCI, not left main, but you will see that still speaking about left main. So the first speaker is will talk about how should I treat distal left main bifurcation disease, patient-centered approach by my associate Thierry Lefevre.
And I want to start with this thing that we learned from syntax and Excel. I think it's very important. I think the previous conclusion of my colleague from surgery was excellent because we are going in the same direction. So what we learned first from syntax is that the outcome is dependent not only on the characteristic of the patient, but also on the center. And you can see clearly in this slide that there is center of excellence for PCI, center of excellence for surgery, but they are not always the same. So you may have a very good center for PCI who is not very good for surgery, and the opposite. And this is exactly in concordance with your suggestion from surgery. We learn also from Excel that the outcome at 10 years in patients who had left main PCI is as good as surgery in terms of death. So as you can see, the two curves are superimposed. And it's true not only for patients who had a low complexity or intermediate complexity, but also for patients who have higher complexity. So I think it's a very important information that we had from syntax. We learned also, and this was pointed out by S.G. Park, is that leaving some residual syntax score is very important in terms of outcome. And it's true for surgery or for PCI. And you can see that the level of residual syntax score is not very high. So with 8 points of residual syntax score, you have an outcome in terms of death, which is very poor. So leaving, for example, a chronic CTO of the right, while treating the left main only, is not good for the patient in terms of 5 years outcome. We learn also that the syntax score 2 is very useful. So not only looking at the complexity of the lesions, but also the complexity of the patient in terms of age, gender, peripheral disease, pulmonary disease, etc. And this has a very strong impact of outcome. And I will show you an example. From Excel, we learn also that if we can treat the patient, the left main, with only one stent, we have a very good outcome as compared to the use of 2 stents. So of course, sometimes you need 2 stents, but it's very important to think about provisional approach when you treat the left main. And Patrick showed exactly the same 10 years ago in the syntax study. We learn also that the technical issues are also very important when you do PCI of the left main. And this is longitudinal compression of the stent. In Excel, it occurred in 7% of cases. And you can see how is the impact of on MACE at 3 years outcome. So you double the risk of MACE if you have longitudinal compression. So now let's take 2 extreme examples. So this is a young patient who was admitted from the mobile care unit directly in the cath lab for unstable angina. And you can see that we have a very tight stenosis of left main, Medina 100 lesion. So the patient is really unstable. There is some EKG changes. So this kind of patient has a very low syntax score, no comorbidities, and the outcome if you treat the left main the long-term outcome will be good. So of course, you need to have good tips and tricks, wire both branches, then stent up to the ostium of the left man, and you need a good optimal view for putting the stent at the right place. Then you deploy the stent, you do a proximal optimization technique, which is very important when you treat the left man because of the different sizes. You go through a distal strut, and then you can do a kissing ball inflation. And at the end, you will have a very good result and very good outcome. So this is a simple patient. Now takes another patient who is very old, with diabetes, high blood pressure. The patient had moderate airborne angina since the last 2 years, and then she was admitted for prolonged chest span of 30 minutes with troponin elevation. And you see renal function is not very good. And this is the EKG 1 hour after the onset of chest pain. And you can see that there's still a lot of ST segment depression. So it means that the lesion is very complex. So this is the angiogram, and you can see that it's a very complex disease, a lot of calcification. It's a 1-1-1 bifurcation lesion of the left main. This is another view. And this is the right, which is also diseased, with collaterals coming from the right to the left main. So I think many people will say we should go to surgery in this kind of patient. But now syntax score can be useful to determine what is the risk of the patient if she's going to surgery. So 86 years old, 3-vessel disease, syntax score is 36, ejection fraction 52, you saw the renal function. So if you use a syntax score to predict the 4 years mortality, you can see that 4 years mortality is 44% with surgery. If you do PCI, it's 17%. So clearly, if you have experience, you can treat this patient with PCI with an outcome which will be better than surgery. And this is what we have done. So of course, you analyze carefully the lesion, looking at where are the difficulties, which kind of technique you should use. And in this case, we start by treating the Alaide first, then do a pot, then exchange wire, then treat the ostium of the circ, and do a T-stenting approach because the circ was very severe. So this is final result after the procedure, and the right was treated 3 weeks later because there was collaterals coming from the right to the left main. So we thought that it would be better to treat the left main first. And this is the result on the right. So my conclusion is that if we have to decide between surgery and PCI, when the patient is at the tight left main stenosis, of course, it's very important to look at the lesion complexity. And of course, patient with 3-vessel disease should be, in the majority of cases, treated by surgery. But you should look also at the experience of your center. What is the result that you have with surgery in this kind of patient? What is the result that you have with PCI? And of course, it's very important also to have collaboration between operators. And I think it's very important to have this cooperation to help younger physicians to learn how to treat correctly left main and multivessel disease. Of course, you should look also at the residual syntax score, because if you leave a residual syntax score more than 8, of course, the outcome of the patient will not good. So this kind of patient should go to surgery. Of course, you should look at the comorbidities, and it may influence also your decision. And at the end, the patient preference is also something very important in the decision. Thank you very much for your attention.
Thank you, Thierry. So we'll move to the next talk, which is Bifurcation PCI at the Crossroads, New Physiology-Guided Decision-Making 2021, will be done by Bon-Kwon from Seoul, Korea.
Thank you. So my topic today is about the new concept on physiology-guided decision-making. So let me briefly remind you the past and present on the physiology for bifurcation lesions, starting with biophysiology. We know that the anatomy or the angiography IVUS FFR is very good, but there are several limitations and pitfalls in the assessment of bifurcation lesions. And also there are very unique nature of side branch lesions in terms of size, myocardial territory, and stenosis mechanism. And that's the reason why there are so much discordances between angiographic severity and FFR. So for this one, which looks like 011 bifurcation lesion, FFR shows that both Alaide and diagonal FFR is not low. And this one, which looks more severe than the previous one, 111 lesion, angiographically, Alaide FFR negative and diagonal FFR negative. And this one, Alaide positive, diagonal positive, so that I can say this is a bifurcation lesion. And this one, which seems to be at best moderate stenosis, but Alaide FFR 0.73, diagonal FFR 0.77. So this is a bifurcation lesion which needed treatment. And I can say that this is not something local, and it happens everywhere. As you can see in this 5 jailed branches, if you measure FFR, you'll find something different from your expectation, except for this one, 0.67. This one is 0.93, 0.95, 92. For this ambiguous lesion, 0.74. So that's the reason why we are applying physiologic assessment in coronary bifurcation lesion. And since the publication of this study on using FFR in jailed side branches, lots of knowledges and insights have been accumulated in this field and changed our concept and practice pattern as shown in this practice flow from the Korean, Japanese, and European bifurcation club consensus. And having said that, I would like to talk about what's new in 2021, focusing on the clinical relevance, non-hyperemic pressure ratios, and new technique and technologies. So let's start with the clinical relevance. So this is now a famous study which shows you the myocardial territory between the main and side branches. As you can see here, diagonal branch, obtuse marginal branch, ramus branch, the territory is much smaller than the main branches and generally smaller than the distal Alaide territory. And what is important is that this territory can be highly variable according to the number and internal and external dominance issues from the 2.7% to the 18%. So this is why it is complicated to assess the importance of side branch territory and relevance. And also it is important to learn that the myocardial territory is much larger and ischemic territory is much smaller than the myocardial territory. So in this case, after Alaide stenting, this big diagonal branch has gone, and you may consider this should be the ischemic or the infarct territory, but the follow-up MR showed that the myocardial infarction territory was only 7.3%. And as you can see here, even with that infarction, there's no regional wall motion abnormality. In an MPI study where the MPI was performed in severe disease in all diagonal branches, average percent ischemia was only 8.4%, and percent ischemia more than 10% occurs only in 35%. This concept is important because while we are focusing more and more on side branches, treating with stent for the side branches, there will be a loss in main branches as shown in the DK Cross-6 study, Cross study, SMART registry. As we are treating more and more side branch lesions, there's more event in the distal main branch and proximal main branch, and also in the main branch event. So in terms of clinical relevance, we have to understand that the side branch myocardial territory is small and its ischemic territory is even smaller, so that the selection of right target is more important than how to assess, including the physiology and how to revascularize. And we should pay attention to maintain the procedure and physiologic success of main branch, because that the main branch FFR after stenting is a key determinant of cardiac death or MI in these patients. And let's talk about the non-hyperemic pressure ratio. So in the beginning, physiologic index, there was only FFR, and we know that there are lots of non-hyperemic pressure ratio, such as IFR, RFR, DPR, and DFR. So what's good is that these indices do not need a hyperemia, and most of these resting indices have a similar diagnostic and prognostic performance. Here is a case example of 57-year-old lady, 011 bifurcation lesion. So when I decided to start with the physiologic indices, so Alaide FFR is 0.88, so significant. So both circ and Alaide needs intervention. As I started with the pressure wire in Alaide, it's not that difficult to recross that pressure wire into the circumflex after stenting. And this is a non-hyperemic pressure ratio, so we don't need a hyperemia, just one click. Dual circumflex FFR IFR 0.27, and after circumflex balloon, one click in 5 minutes, in 5 seconds, I can get the 0.5 value, and after 2 stenting, final IFR was 0.92. So it doesn't take that much time, and it's easy. And one good thing of new technology using non-hyperemic pressure ratio is a co-registration of imaging and physiology while combining angiogram and IFR pullback information. So previously, what we can have in this diffuse LAD diagonal lesion is the IFR 0.89, but when we combine this information together, we can get this co-registration images where the one dot represents the delta IFR 0.01. And as you can see here, dots are quite diffusely spread so that it's not an isolated osteo disease, it's a diffuse disease. In contrast, you can see that this is a really, really focal physiologic disease which needs a treatment. And one good thing of this technology is that we can predict the post-PCI physiology with this, so that with some click, you can have this value, which seems to be an estimated post-PCI circumflex IFR value should be around 1.0. And this is measured IFR value after 2 stenting for that left main, and it was 0.99. So for non-hyperemic pressure ratio, it's more convenient and less influenced by other lesions. And co-registration enables the prediction of post-PCI physiology results. However, we definitely need more studies. And one thing we should remind that the non-hyperemic pressure ratio should be measured in true resting status, because that this two same location, same patient, one is 0.88, the other is 0.64, because this is measured during the patient vomiting. So now, finally, talk about the new technology and new technique. So let's start with the DCB treatment, Physiology-Guided. So this is a 59-year-old lady with stable angina, 001 true bifurcation, a true isolated diagonal branch lesion. FFR was 0.55. When I did a pullback, as you can see here, there's a big step up. So what I decided was that to do a DCB guided by physiology. So this is an angio taken after balloon angioplasty, which is good, so that it can be a good target for the drug-coated balloon treatment. So this is FFR achieved after drug-coated balloon, so that this is a kind of an example of DCB, FFR-guided DCB treatment. And there have been recently some data which support the use of physiology-guided DCB treatment. And in this study, at 9-month follow-up comparison between the DCB, physiology-guided DCB and stent implantation, you see that there's a similar functional gain and functional maintenance between the DCB and stent treatment. And this also can be nicely applied in the bifurcation segment. As you can see here, after DCB treatment, there's no carina shift there, and the side branch ostium has been actually enlarged during the follow-up. And another new things can be done with the new image-based physiologic assessments. Here is the case example of CT-derived FFR in this ambiguous left main isolated osteo disease. FFR was 0.83. And now if you have a CT scan, you can also achieve this number from the non-invasive physiologic assessment or the CT-FFR. So in this case, CT-FFR value was 0.83. And one good thing is that you can also use this technology for the prediction and planning of your treatment strategy. So in this very complicated trifurcation lesions, you can plan your several strategies and having the post-PCI physiologic value with the simulation. So in this case, predicted FFR following plan B was 0.84. And when the PCI was done and FFR was measured during the live demonstration course, so it was 0.85. So we know that there should be more things to do, but this is a kind of fancy story that we can follow. Another new case in this field is that angio-derived FFR. This is 001 diagonal branch osteal lesion where the FFR was 0.86. Although we need more data on this isolated osteal lesions using angio-derived FFR, but here in this case, contrast vessel QFR was 0.89, quite similar to the measured FFR value. So for the new technique and technology, physiology-guided DCB treatment can be a promising option for bifurcation lesion, especially for side branches. And imaging-based physiologic assessment can be helpful in estimating the functional status of coronary stenosis and also predicting the procedure outcomes without invasive procedure. However, further studies are definitely needed for this new case in our field. So I've been briefly reviewed the new concept and techniques on physiology for bifurcation lesions, mainly focusing on clinical relevance and non-hyperemic pressure ratios and new technique and technologies. And I think adding this new information into the established practice flow will definitely enable more appropriate assessment and treatment for the patients with bifurcation lesions. Thank you very much for your kind attention.
Thank you very much, Cohen, for this beautiful talk. We move to the last presentation in this session, which will be upfront double stenting for bifurcation lesions. When and how will be done by Chaoyang Chen from Nanjing in China.
I think the topic is at least presented more than 1,000 times by different speakers, but it's still interesting. So far, I don't know when is the time for upfront two-stent technique for different kinds of bifurcating lesion. So let's go through. Basically, I have nothing to disclose. So basically, so far, according to the 2018 ESA guidelines, so the provincial stenting technique should be the preferred approach for most bifurcating lesion. The exception is that for larger side branch larger than 2.75 millimeter in diameter with a long osteal side branch lesion length longer than 5 millimeter, or anticipated difficulty in accessing an important side branch after stenting main vessel and the true distal left main bifurcating lesion. I think this is the first criteria to tell us when to perform two-stent technique for given bifurcating lesion. So let's back to syntax score. So also from the same guideline, it provides the table 6 to tell us how to calculate syntax score for bifurcating lesion. So clearly you see for false bifurcating lesion, so the points is limited to 1, but for any sub-branch involvement, it means for any kind of true coronary bifurcating lesion. So the scoring should be by 2 points. So inside the analysis from the different kinds of true coronary bifurcating lesion, so far I do believe only Medina 111 or 012 bifurcating lesion are real true coronary bifurcating lesion. For example, for 001 or 101, even there is involvement of side branch, but the anatomy of a bifurcating area should be pretty simple. Particularly, from syntax score, a bifurcating angle less than 70 degrees as one additional point, So far, I don't know what the evidence coming from, but in general, for any true coronary bifurcation lesion, and the bifurcation angle may correlate with clinical outcomes. So the first issue is how important of side branch size. My colleague, my friend, Dr. Koo has addressed the importance of side branch length. So this is an example for a young man patient. So from angiography from epicranial and also aerial cranial, so you can see very calcified lesion from the beginning of AD to the distal part, very severely diseased bifurcation lesion involving AD and the diagonal. From angiography, because the Gaudino case was a 7 French, so from aerocranial, so probably the distal AD and diagonal diameter very less than 2.5 millimeters. Cause this is Medina 111 bifurcation lesion, but definitely sub-branch lesion length longer than 10 millimeters. Another very, very important thing is that we could not identify the real origin of the side branch because of the ambiguous bifurcation angle. So we after pre-dilation using 1.5 balloon, we checked IVOS for both AD and diagonal. So the picture clearly shows both AD and diagonal are not small vessels. So I think this example shows sometimes for some case, so vessel size is commonly underestimated only by angiography. For this case, the proximal diagonal a vessel diameter is around 3.5 millimeters, so it's not small side branch. So if we only rely on the angiographic finding, so it will induce a different use of standing technique. So this is an example. So let's back to our combined database. We combined our DK2, DK5, and also DK6 trial. From this trial, so there are 702 patients were treated using provenance standing technique. We tried to calculate the distribution of individual components of clinical outcomes according to the side branch lesion length. From table, you can see clearly from side branch lesion length less than 5 millimeters to minimal 10 millimeters. So the risk of cardiac death, target vessel cardiac infarction, clinical-driven target lesion revascularization, and primary endpoint target lesion failure increased double. This finding is recently confirmed by another meta-analysis by Jiu. So the conclusion from this meta-analysis is that clinical benefit of two-stent technique was observed over provenance standing technique in bifurcation lesions with side branching lesion length minimal 10 millimeters. So far we can conclude that there is a very strong correlation of side branching lesion length and the clinical outcome. So I think this is a very strong reason why we tried to establish a new definition criteria. So finally, we provide one major and 6 minor criteria. One major and any 2 minor criteria could be used to define a complex bifurcation lesion. Even it's not perfect, but I think it will be very useful for our daily practice. Since the publication of definition criteria, so another group from Beijing Fire Hospital analyzed retrospectively analyzed 928 patients with left main bifurcation lesion. Of these patients, so the complex lesion was seen in almost 30%, very similar to our basic definition 1 study. So final finding was that so definition criteria was able to risk stratify left main bifurcation patient. Finally, two-stent technique yielded very low myocardial infarction and numerically low 3-year cardiac death regardless of left main bifurcation complexity. So for the definition criteria, it was my first time to try to compare the differential clinical outcome between simple and complex bifurcation lesion from our DCAP 5 study, which only included distal left main Medina 111 and 011 true coronary bifurcation lesion. So finally, from the figure on the right panel, you can see there were very significant difference in terms of the 1-year primary endpoint, the TLF, between a DK quality and a prominent standing technique for complex bifurcation lesion. On the other hand, on the left panel, you can see for simple distal left main bifurcation lesion, no significant difference in p-value between DK quality and prominent standing technique. Even this is the only subgroup analysis, but I do believe it provides a trend to show the benefit of DK quality, kind of a two-stand technique for real complex distal left main bifurcation lesion. Once again, recently published our definition 2 trial, which only included complex bifurcation lesion defined by definition criteria. So finally, we got a very significant difference in terms of the 1-year tight lesion failure between provisional standing technique and two-stand technique. In this trial, DK quality was used in almost 78% of the lesion in the two-stand group. So when I say briefly summarize the time to perform two-stand technique, final 2 slides, I'd like to show how to perform two-stand technique. Because of the time limitation, I will provide one video to show how to do DK quality technique. It will take 1.5 minutes. So in general, we need to wire main vessel side branch, a long balloon in main vessel, standing side branch. For some cases, we need to use a short non-compliant balloon to make a side stand well opposed. After that, this is the first balloon crush. Because the balloon diameter is just according to the distal main vessel diameter, could be small. So we need to use So these are still images from the video. So in general, so far, I think we are very close to the beauty of DK quality technique. Technically, from the video, you can see after first balloon crush, we need to use another large non-compliant balloon to completely crush the side stand. I think this is very important, particularly for distal left main bifurcation lesion, because of the wide discrepancy in the vessel diameter. After that, always we recommend proximally rewiring. Very good kissing balloon inflation with relatively short overlapping of 2 balloons in the main vessel. Final part. So this is a last slide to show whole message. So in general, provisional standing technique works well for simple bifurcation lesion, so which accounts almost 70% of our bifurcation lesion. Systematic to stand, particular DK quality, is associated with low rate of TLF at 1 to 3 years of follow-up for complex bifurcation lesion or distal left main true coronary bifurcation lesion. Definition criteria used friendly to identify a complex bifurcation lesion have been confirmed by meta-analysis, consecutive study, and also RCT. But so far, still there are several issues to be answered. So the first issue is the comparison of provisional with one stand and versus provisional with two stand technique for bifurcation lesion. Second issue is the comparison of provisional with TE versus provisional with TAP technique. Finally is IVOS OCT or FFR guidance superior to any others. Thanks for your attention.
Thank you, Seung-Jung, for this nice talk. Dr. King, first question.
Well, there are a lot of techniques, and certainly what I'm observing is that certain centers concentrate on what they do. In my place, DK Crush, largely through the influence of Shaoling, has been the predominant techniques that's used, but I see other people using culotte and using a more provisional. Shaoling, is the technique the most important thing, or is it that you become expert at whichever technique? Is that important?
Yeah, I fully agree. I think for any intervention cardiologist, one weapon is not strong enough for all enemies. I mean, for all kind of bifurcation lesion. I feel that we have to become the master of provisional standing technique. That's the first step. Next, we have to very to be familiar with at least one kind of two-stand technique. From my side, from my hand, I'm very confident about the DK question for real complex bifurcation lesion.
I would like to hear from Dr. Banning and Dr. Nakamura with questions if you have, because we haven't gotten you involved yet.
It's been a great session, hasn't it? And I started off thinking how exciting it would be for us to do another randomized trial with surgery and incorporate many of the lessons that we've been hearing about how we know now what we do know. But of course, there's an awful lot that we still don't know. And it strikes me that technology has moved on dramatically, really, even since we did Excel, with regard to our understanding about both the physiology of the bifurcation and how we should optimize our treatment of it. And I think ultimately the challenge may well be that you need to remember that Excel was terminated early because the sponsor ran out of money. And I wonder whether we'll ever have the funding to do a major head-to-head surgery versus angioplasty trial again. That said, I would probably say that ultimately, I would agree with our surgical colleague that the clinical decision usually makes itself, that there are factors which determine which is going to be best for our patient based on the angiogram and clinical factors. And our job is really to make sure that we do our job as well as we possibly can. And I think it's been inspirational to see some of the insights as to how we can continue to evolve our technique going forward.
Sure. I didn't mean to leave Dr. Do-Yoon Kang out of that request for questions, but chime in if you have one. And Dr.
I have one maybe for Seung-Jung Park. He was in his talk. He was supposed to speak about future guidelines. So, do you think that in the guidelines we have to define a volume and experience, teamwork, or words like this are important for left-man stanting, of course? Don't understand my question.
Yeah, I think SJ is muted. SJ, can you hear me?
Yeah.
Yes.
I have a question for you, Seung-Jung Park. Do you think in the future guidelines we need to put some data on volume for the operators, or experience, or teamwork, and material in the environment? All these things are important or not?
All right. All the variables are related with expertise, right? I would say in terms of a bifurcation PCI, we have very important insight from the Ives, study. Just Dr. Gu mentioned about even we consider about the function, the most important thing is vessel size. So actually for future perspective in bifurcation concern, from the ischemia studies, right? You know that the single vessel disease, actually stable angina is not the, PCI disease, right? The meaning is almost even there are some disease for side branch concern, 70% of cases, personally, I think we don't need intervention, right? And the main branch is main concern, even in whatever, bifurcation disease, except the main bifurcation, right? Main bifurcation is pretty enough for circumflex artery. And so that very simple, normal looking circumflex we can do a single stent crossover provisional stent. There are some true disease, upfront to 2 stent, upfront to 3 stent would be okay for main bifurcation, main trifurcation, and big vessels. And in terms of IVUS, effective, stent area concern, diameter wise, 2.5 is maybe enough to treat, right? The meaning is effective stent area at least 5 millimeter square. So we included some functions, FFR concern. Really, we cannot touch any bifurcation lesion in the practice. Even after the main branch crossover, some, angiography compromised the whole side branches and no chest pain, just leave it alone, right? Some medication is quite enough to maintain the clinical relevance concern. So I suggest, all right, technique-wise, we do upfront to stent, right? It's good. However, personally, I think we have to, change, move in some point of clinical relevance and function is more important for any bifurcation lesion, right? Whatever we use to stent, crush, that is important. However, the more important thing is concept. We have to change. I personally think so. Right? All right.
Nakamura Sensei, you have a question.
Just a short question about regarding technique. For one Thierry and for one Sharon. I completely agree with you, Thierry, about your idea about the bifurcation stenting. Just one question to you is just a single, in the case of a single crossover stent in the left main, do you still do KBT all the time? Second question to the Sharon is if you want to get optimal DK crush stenting, do we need IVUS all the time to check in stent position? This is two questions to Thierry and Sharon.
Yeah. So to answer to your question, so now when we do a crossover, we like to open the strut toward the side branch in terms of optimal rheology, optimal outcome of the patient at long-term follow-up. So we always do a proximal optimization technique, sizing the stent according to the distal reference of the Alaide, and then open the strut toward the side branch with using a non-compliant balloon in the side and semi-compliant or non-compliant in the main. But I just want to add something to the discussion of Xiaoling Chen. So he showed a very nice example of a true 1-1-1 bifurcation lesion between Alaide and diagonal. The diagonal is clearly a relevant branch, bigger than 2.5. It's a unique diagonal. And for sure, in this case, I will use 2 stents. No doubt about that. So I will do a provisional approach with 2 stents. Xiaoling will do a DK crush because he likes to do it. And we can come back to the question of Spencer, is it better to use the better technique that you have in your hands, or to use one specific technique? And I think it depends really on the experience that you have. And today we have no clear data showing that one technique is better than the other one, because in the older study, DK Crush study, the provisional was not optimal provisional as we do it. So at the end, we use 2 stents when needed, but not always.
Well, thank you, Sunao, for your second question. Absolutely, I think intravascular image guidance is very, very important to improve the quality of standing technique for bifurcation lesion. Let me tell you another story. So, DK Crush A study comparing the angio guidance and IVOS guidance for by 3 complex bifurcation lesion is ongoing. So hopefully after 3 years we can provide the 1-year follow-up data. Thank you.
I have a very short question to Dr. Koo. You showed a very interesting cases of physiology-guided default of angiographically gel side branch after crossover stenting. And in those cases, do you prefer FFR or non-hyperemic IFR in those situations? Which would be better?
Well, actually, I think that's a practically important question. So nowadays, I prefer to measure both resting and hyperemia indices, because especially for left main, because considering the territory of the circumflex artery, I think it is important to have both resting and hyperemia. And if anyone is positive, I would consider fixing the lesions.
Yeah, Dr. Koo, I have one question for you. So in terms of the angio FFR, which is very popular now, in the mainland of China. So my question is that, what's your opinion about the angio FFR for a guiding bifurcation standing?
So I think that's another very practical question, because after having more data, that the angio FFR will be in the guideline, I guess. So I think that still it needs some more improvement for the planning the treatment for delicate bifurcation lesion, because as of now I know that it has limitation in ostial lesions, and for left main bifurcation lesion it still has some limitation, especially involving with the ostial lesion, so that it's a promising tool, but I think for bifurcation lesion, it definitely needs further studies and further refinement for its technique.
Thank you.
I think we're just about out of time. Dr. Louvard, do you have any closing comments for us?
Yeah, I think we had a very nice discussions, the kind of one we had many times, but I've discovered today some change in physiology, the potential for Chaoyang Chen to have studied provisional with 2 stents versus DK Crush. So I know that you have the potential to do that. So I think we can prepare even more exciting future meeting in person, I hope. So I thank you very much, Dr. Park, for organizing this session. Thank you very much.
Thank you.
It was excellent. I enjoyed everyone's presentation. And SJ, once again, thank you for engaging all of us in your excellent TCTAP meeting.
Thank you. Already.
Bye-bye.
Thank you. Bye-bye.
Bye-bye.
David, Kandzari.